Too much of it, but I want to introduce, Marc Rothman. Marc is a physician executive and subject matter expert in many areas of healthcare, including aging, geriatrics, dementia, post-acute, and home-based care. He is the founder of Dementia Spring, a nonprofit organization focused on improving the lives of people with dementia through education, resources, and innovation. Dr. Rothman previously served as Chief Medical Officer at Signify Health, which I believe sold to CVS for $90 billion last year or the year before. This year, okay. And held other executive medical positions at leading healthcare organizations, including Aspire Healthcare, Kindred Healthcare, and Kaiser Permanente. So welcome, Marc, for coming and joining us tonight. Dr. Ross Hoffman is Chief Medical Officer at Centene and is a board certified cardiologist and currently the Chief Medical Officer Innovation Lead, like I said, at Centene Pharmacy Services Organization involved. Prior to serving at Centene, he held the management roles developing products for healthcare, IT companies, and payers, served as Senior Medical Director, VP Product Development at Med Solutions, now Invocor, and Express Scripts, and founded a neurotechnology biomedical device company in the early 2000s. He also served as president of Cardiology Partners, a cloud-based cardiovascular imaging and consulting company. Ross, thanks for coming as well. And then last is our Chief Medical Officer, Dr. Mehrdad Shafa. Shafa is CEO and Chairman of avixena Population Health Solutions. He also goes out in the community and chucks the people that are not very efficient in what they do in their clinical services, right? As well. So I watch what I say around Dr. Shafa on a regular basis. He's a recognized authority in population health management, resource utilization, and medical quality management and outcomes. He has more than 20 years of experience in pediatric emergency medicine, and throughout the past 15 years, Dr. Shafa has worked for 23 health plans across the U.S., serving as Chief Medical Officer and Executive Director for 13. He is founder of avixena Population Health Services, a SaaS-based provider of evidence-based decision support tools designed to prevent costly and preventable readmissions in facility post-discharge care. So just to point out really quickly, Judy kind of went through this a little bit, but as Judy pointed out earlier, the U.S. healthcare system is under siege with spending reaching $4.3 trillion in 2021. I think when I started back in 2006, it was probably 2.5 trillion at that time, right? And now it's up to 4.3. We developed a lot of tools along the way, and it's still elevated, right, as far as the cost is concerned, right? So compared with 1.4 trillion in 2000, there's clearly an escalating burden on the system of care in the United States, beyond the obvious concern over the magnitude of healthcare spend as a population of our gross domestic product. An underlying challenge is that the system of healthcare in the United States is on a pathway to fracture under its own weight. This is further exacerbated by our own population aging, with Judy pointed out 1 out of 5 U.S. is expected to reach age 65 by 2023, alongside an unprecedented exodus in turnover of clinicians due in part to poorly implemented technology. Beyond these macro challenges, I'm almost done. A wide array of healthcare enterprises are operating with significant financial losses. I think Cleveland Clinic's reporting $1 billion per quarter right now of losses, and impeding their ability to invest in new technologies. As a result, it is evident we are well on our way to an unsustainable situation. Today, we're going to discuss the ways in which we are reshaping care delivery and the healthcare industry and improving patient experience. Before I jump into the questions, I want each one of the panelists to kind of go through and give me your, 2 minutes, 3 minutes of where you see healthcare and where it's headed today from that. So Ross, let's start with you on that. Sure. Yeah.
My lived experience includes 20 some years practicing medicine. I practiced in urban areas in academic facilities and also in rural America. So I bring sort of all of that to informing my impressions, and then of course sitting inside of health plans and other management organizations and looking at other things like cost trends and seeing what the big drivers are. And so as for where we are, I think that's sort of been enumerated through Judy's data. And why is that happening? It's truly really complicated. I'm going to try to limit scope to sort of the medical, what we consider healthcare as opposed to non-healthcare for the moment. And that may be problematic because the non-healthcare has a lot to do with determining our health, as I think has been more prominently discussed over the last 5 years, but and not newly, but more prominently. We have really fragmented systems, and some of that is determined by the way the system is architected and in terms of payment. But it's also, and I think this is an important point relative to Life365 and how it finds a path to even greater success, is the delivery system itself is fragmented. We've done things, and I think we doctors kind of gave away the keys to the kingdom a little bit in health systems in particular, which enabled this to occur. So an example would be sort of a historical point to consider is the care of patient over time in a community. There was once upon a time when your doctor actually took care of you for all of the episodes that you experienced. And I lived that, and actually I remember so I went from Boston to Grand Junction, Colorado, and I could not believe that there were OB groups of obstetrics where you had a call rotation. But if there was a patient where you had established care, their standard of practice was your obstetrician delivered your baby if you were in town. I mean, if you were out of the country, it's something else. And that was their standard. And I give that as an example of sort of the personal commitment to the field and the recognition, I think, of practitioners and how important it is to sort of have that trusted patient-provider relationship. And I think much of which has devolved over time has been the migration away from a sustained, definable, strong patient relationship between the patient, and it could be a provider team, Ken, or an individual provider, whether that be primary care or otherwise. We witnessed, sort of the gradual trend over time within hospital systems to bring in something called hospitalists, which are very transactional. Now, there are some justifications to that one could make from a medical quality sort of expertise point of view. But what you then introduced was this post-acute problem, which was Dr. X took care of the patient in the hospital and signed the discharge orders, and then they were it says follow up with primary care on your discharge. There's no really accountability in that transfer. And, I think the industry has recommended that, there are organizations that exist around societies of care coordination and so on. But patients would fall into gaps, and then eventually figured out that patients are getting readmitted and so on. I think there's been, and then the last piece that I would say that exacerbating things is affordability and benefit coverage. So we are progressively putting more of the risk on patients, and the system is harder to use. So even for patients who have full benefits, and Centene has a large Medicaid population, they have coverage, but they don't necessarily have ready access. And so when they need help, they're not really sure how to get it. They might have an FQHC in their community, a qualified health center. But again, depending upon the sanctity of that relationship that they have, they get follow-up or they don't. And so this issue around patient and provider engagement, creating a system that's navigable and readily affordable is problematic. And so we have the practitioner system that is not completely linked together from a coordination perspective. And then we have a system that when you have a problem as a patient, it's not necessarily easy to know exactly where to go. I'll probably pause for a moment.
So yeah, you're evoking a lot of thinking in my mind right now, because I actually asked this question downstairs. You know, I'm finding a lot of people, and I'm going to direct this to you, Mehrdad. You actually said when you discharge, you know, seek your primary care. But I'm finding actually that probably 5 or 6 of my friends don't have a GP anymore, right from that. And we're also finding that when I go to a specialist or to a GP, they're actually owned by a health system, and they're saying go to the emergency room if you can't get in, right, as well. So Mehrdad, what's up with that?
Yes. My story is a little longer. I finished medical school in 1982, and my first job out of medical school was I was physician advisor for utilization review at a hospital in Pontiac, Michigan. And I would assist people getting discharged. And I realized the disconnect and the service that people were getting, patients were getting at the time. I was the agent to implement a new program in the hospital called DRGs, Diagnostic Related Groups, October 1, 1983. Later in my career, I became interested in medical outcomes. Question was, how do you say which of these 2 doctors are better than the other one, which is more effective? And to this day, there is no tool saying that the quality of care that is provided to individuals can be accurately measured. People know they were treated well. They don't know if they were received the right care. We don't know that to this day. I have seen the birth of managed care. I've seen the birth of hospitalist system. I've now seen value-based care, quote unquote value-based care. Over the past 40 years, basically, system has become more fragmented, more complex, less user-friendly. And healthcare has steadfastly resisted technology and adoption when it comes to patient. It is good when new technology for diagnosis is introduced into the market. It has adaptability, but not when it comes to patient care.
Are they resisting technology, or are they resisting the fact that they're not being paid for it?
Payment methodology is not there. We have paid for the wrong care over the past 65 years, 55 years, 57 years, Medicare has been in existence. You, as long as, just say what's the reality of it. You have got 17.9% readmission rate in the United States. And you've got 200,000 preventable death in US health systems every year. You've got 80,000 hospital-acquired conditions in the United States every year. And you're paying for it. We are paying for it. As long as you're paying for it, then there's no impetus. There is no motivation to change. But what is happening right now is that with aging population, 10,000 new members joining Medicare on a daily basis until 2028. 10,000, remember this number, 10,000 a day until baby boomers retire. And then you've got a mass exodus of physicians and nurses. 2 million nurses will quit in the next 2 years. And the only solution left here right now is technology. And you notice that payers, CVS is cutting, Aetna, cutting 7,000 jobs. Centene announced job cuts. Today, Elevance, which is the largest Blue Cross in the country, they announced cuts. Everybody's losing money because care is more and more fragmented. Technology is the only viable solution here to provide a patient-centered care. This is where we have to go. Right now, I'm giving you some stats, those are not my stats. An average Medicare fee-for-service, regular Medicare, seen 19 different providers in a year and receives 51 distinct prescriptions a year. Not the same refill. You're talking 51 distinct new prescriptions every year written. And these people live in 8 different health systems. They get their cardiology care here. They get their emergency in this hospital. Primary care is another hospital. And nobody's talking, there's no interoperability between the systems. So here's technology to create a patient-centered care that the world, 8 health systems are built around the patient. And patient is cared for. I pride myself knowing a little bit about population health management. So what is population health management? It's 4 tenets. Knowing the groups and subgroups in your population. Engaging patients and the caregiver to be active participants in the care. Number 3, having a reliable intervention that's going to make a difference. Number 4, reporting and monitoring on this outcomes. You have to do one at a time. You can't just skip one. You can't just do this without patient engagement. You can't do it without reporting. You have to do consecutively these interventions. And if we're talking about population health, it has to be at the person level. It has to be at the person that is, all the information about them, and what their needs are, their behaviors are, and you have tools that can assist them to live longer and get better. We can talk about value-based care some other time. Thank you.
So Marc, you work for Signify, you also work for Kindred, right, as well? Break it down really simply from that standpoint. I know you're a proponent of helping to provide solutions that instate technology that allow people to receive their care anywhere they want to, and a lot of times at home. So what's your why in this industry? I'm trying to move away now from the problem, because we've been giving you doom and gloom now for the last 10 minutes or so, or 15 minutes. Let's move into some healthy thinking of where we think lessons learned, what your why is, and where you're going.
Happy to. So first of all, for everybody in the room who has hypertension or is over 40, you should feel really safe right now. It's like we're all here. This is the safest room in New York City right now.
You're not in the office. They're just going to send us to the emergency room.
Right. We literally have a cardiologist, a geriatrician, like we just need a pediatrician.
Yeah.
Round it all out. I will not rehash what's already been said. They've said it very eloquently. I've spent my career diving into a lot of the places where these gaps are. I've seen it from the highs and the lows. I went to Kaiser Permanente so that I could experience what fully integrated, vertically integrated healthcare felt like. I needed to understand how it could be. How good could it be? And the answer is that it can be pretty good. The problem is there's still black holes. You mentioned post-acute care. You get discharged from the hospital, go follow up with your primary care doctor. Well, those 2 things are 7 weeks apart. Nobody knows what happens in the middle, so I jumped into post-acute long-term care so that I could lift the lid off the black box of post-acute long-term care, rehabilitation, nursing homes, home health, hospice. What the hell is happening in that period of time before you get back to the PCP? And what I discovered there is that innovation and change and improving healthcare outcomes is actually not that hard, because the evidence base for all of this stuff is actually pretty darn clear. We are not at the beginning of our journey. Luckily, Mehrdad, 30 years figuring it out for us. Like, it's not all that complex. The ability to deliver better care, if the providers would do the right thing, if they could communicate effectively, if we had the information at our fingertips, if we made the access points easier and we engaged the members, the patients, can actually improve healthcare. And all of us have been involved in dozens of performance improvement projects. The hard part is that those improvement projects themselves become disconnected. It's hard to make those changes endure, especially when you step outside of an integrated system, which is what I then did when I went to Kindred, and I tried to, Kaiserize the real world. And the real world does not want to be Kaiserized, fascinatingly enough. The doctors themselves don't make enough money in the system to make them happy. And there's all kinds of other, constraints. The technology, someone mentioned George Halverson. So the reason I went to Kaiser Permanente was that I read his book And he was about to invest $2 billion in putting Epic into 38 hospitals in Northern and Southern California. And I picked up my family in New Haven and said, we're going to California because I want to experience what that can feel like. Now, it turns out the end of the story wasn't written yet. The end of the story is that the electronic medical record was ultimately a tool for billing. That's how the majority of investment and attention and exploitation of that system has been utilized, to the chagrin of folks like us who would like to use it less for billing and more for quality improvement, safety, and patient care. But that was one of the reasons I went there. The real world is not integrated, right? And then at Signify Health and at Aspire, essentially what I did was bring practitioners into the living rooms of Americans, which is not an easy thing to do because Americans do not like strangers in their living room. So you call 100, and if you can get 25 or 28 to agree to a visit, you've succeeded. And literally we are offering a doctor, a nurse practitioner in your home, looking at everything that you want looked at holistically. And the reason that they love us in the living room is because we're holistic. We don't do the 8-minute visit with an antibiotic and send you home. We don't do the quick test in and out and give you, 4 more appointments and 4 more systems. We look at all the medicines together by all the doctors who have written them. We look at how you walk and how you interact with your environment, whether you're safe. We look at how you manage your own diseases and help you with tools. And we do some of the diagnostic testing in the home. So we're probably the largest diagnostic test in the home company at Signify. And key to that, I really appreciate the mention things of trust and safety in the previous conversations. This is critical, right? If you're going to bring devices, tools, tests, all of which are going to be embedded with AI, by the way, into people's homes, into their lives, you have to vouch as the deliverer of that for the safety of that product. You must vouch for that. You have to build in systems that do that. It's a little extra work. But I really think, when I think it's one of the biggest challenges for healthcare today, immediacy, staffing is number one. For anybody who sits on, boards or works with companies that are trying to deliver healthcare today, staffing is it. Whether that's in home health, in the local hospital. Judy literally described a healthcare desert in the middle of Massachusetts. Shocking. So staffing, number one. I think the other big real problem is sort of capital constraints that are not evenly spread throughout the market. So you've got giant systems who have some capital, you have some that say they're losing money, and then you have a ton of variability where smaller organizations, people who don't have scale, aren't backed by PE, don't have a consumer base to pull from, like CVS to do acquisitions. They don't have the capital. We're not giving away the electronics, quote unquote, for free with meaningful use dollars anymore. They have to actually buy the services. They've got to buy the relationship to some degree. They have to invest in all these things. Nobody's got money to stand up an office of AI integrity in their healthcare system. I mean, that's impossible. They're going to have to contract out for that. So I think constraint of capital in healthcare is going to be a problem that we've not had to live with as much over the last decade, in the next decade. And then I think the last problem that really needs to be dealt with, and there's real opportunity here, is that the smorgasbord is now so big. The joke I said to Judy at lunch, right? Or someone to lunch. We used to joke about Starbucks. There were too many options. It was complicated to order something at Starbucks. There were too many options. If you want to go out and find technology that you can trust in healthcare today, there's too many options. And so that's why you partner with an accelerator, you start a venture group, you try to hire consultants to help you navigate. You literally can't do it anymore alone. And that's an opportunity for organizations like us to differentiate ourselves, to help make things easier for them. One of the nice things about being integrated with so many devices is we can help you through the front door, but then we can stay with you for the rest of the journey. It's not a one and done. And I think that's a real, I think what big organizations in healthcare are looking around for solutions and don't know which first step to take. So there's opportunity there.
Ross, I think, Mark touched on it a little bit from that, but, what role is, the consumer playing in transforming healthcare. My belief, really quickly, is, the decisions in healthcare are being made by the consumer and by the payers, like going forward. But also personalization is going to play a huge role in how consumers vote with their dollars, with how they engage with healthcare, and where they engage with healthcare as well. So, to a layperson, to a provider that says you just took me out of the equation altogether, I don't have a decision, I don't have a voice in how patients receive care. What's your thoughts around how consumers are going to help transform, or how we have to adapt to how consumers think?
Yeah, so I would divide that up into a couple of different personas of the healthcare consumer. So based upon how sick or well they are. So and I'll come back to that. The places where you see movement is certainly around convenience, and that has to do with immediate availability, sort of, where everything in the world now is appified and asynchronously accessible, and people are more used to that. And so I think when possible, you do see people voting with their feet that maybe they're not going to wait to go in and see their primary care doctor for something that doesn't land in the emergency room, but they want some attention, they want clarification, and they can get into an urgent care center or any one of the retail locations that were described earlier immediately. And maybe those places are really building themselves to be much more consumer friendly, because many of them are in fact retail kinds of organizations. So that's in their DNA, whereas the rest of the ecosystem is not quite there. And the rest of the ecosystem is hospital centered or physician centered. Build the practice around the physician, and then the patients come, right? So we've witnessed that trend, and I think that continues to occur. The impact, I think that, what impact does that have overall? I think that from the perspective of the big forces that exist in healthcare, payers and health systems, I think folks are looking at either retention of membership or, retention of patient population in their systems. Nobody wants people leaking out, right? So to the extent that those organizations are able to integrate their poorly integrated silos of specialties and all, and become more connected with the individuals in their community and see themselves as becoming access points, then the voice of the consumer will be heard. To the extent their business model is they don't see it as being dependent upon that, then they may not, and that's changing. So, hospitals will make their money on high cost procedures. So, it's oncology care, MSK, and cardiovascular. And that really hasn't changed all that much over time. I think post pandemic, we're seeing some cracks, and you're seeing, more access points to care. So I think, but that I think for folks who are sick, will be much more gradual. I don't think the persona of the sick individual look as much like a consumer as opposed to somebody who's looking for the urgent care types of care. The other constraint around this, and you mentioned this earlier, is, well, you both did, is the supply. So given reduced access to practitioners, the patient or member is constrained as to sort of how they access the system. And so that lack of optionality, I think, really handicaps them as a consumer. The other element to this that handicaps them, I think, is their benefit design and the ultimate cost. We are definitely seeing some of the inefficiencies. I'm talking, both sides of my mouth now. With really the concluding point that I think this will evolve. But I don't think it's going to be as fast for sick care as it is going to be for some other things. The pharmacy business certainly is being transformed. I think, a little bit around Good RX, which is really just a couponing business built in an interesting way, is one thing. What Mark Cuban is doing, on the other hand, is really exposing the inefficiencies of the legacy system, where using your benefit is more expensive than just going as a consumer to an app and getting your drug fed. I think that's, as long as he continues to fund that, because it's not profitable, as long as that continues to emerge, I think it's having an impact in the rest of the system, where now the federal government is looking in at these gigantic financing organizations and claims processing organizations, saying we need to remove the efficiencies here because affordability and access is a problem. I think in that way, the voice of the consumer is being heard, in a very real way. And you do now hear more, even outside of oncology, but I think it's more in the vernacular, that the concept of FinTox, financial toxicity, that the cancer diagnosis has a financial negative impact on the entire family, where something like 40 to 50% of families with a cancer diagnosis have exhausted all their life savings by the end of the year. That's a consumer kind of phenomenon that I think is shaking the system. The implications are vast, I think, in that regard, and certainly solutions that are brought forward with both people, process, and technology that enable greater continuity and less choppiness, and easier and more fulsome access. As was mentioned, and importantly, measurement of quality, where things like GPT and other elements around patient clones and other journey map tools, such as what Zeus is developing, I think we will be able to measure and report on those things. And once we have those sort of continuous patient journey technologies that are more affordable, and the advancement in technology makes it more affordable, then we can start to layer in these interventions with monitors, assure that they're getting used, because the devices will talk to the rest of the system. And so it's sort of, the robots will talk to one another, and you will get signals for exceptions when it's not happening. I think we can get there, but it's going to take some time.
So, one of the things I keep on talking about is to talk about, a lot of my friends don't have a primary care right now as it is. A lot of them are being forced into the emergency room. But a lot of us are also still looking for more transparency, right, as well, because as our deductibles are getting higher, I think we're actually paying for it. I've actually found that the doctors are writing off the difference between what the insurance would pay, right, and what they bill. They would write the rest of it off. They're not doing that anymore. They're sending bills out, right? They want the whole amount paid for, right, from as well. So it means that, we have transparency with GoodRx, but when a doctor sends me off for a CAT scan or an MRI or whatever, or a Holter monitor, I want to know the price I'm going to pay, right, from that, because that affects my deductible as well. So that's kind of empowering me a little bit as a consumer to make choices. And I know it's going to potentially put more strain on the health system, the care provider, because it may not. I think it's going to, right, from that. One of the questions that I asked Mehrdad from this is, okay, so we've talked about providers are outside the equation. It's a consumer-driven market, it's a payer-driven market, right? The providers are losing people. We lost 175,000 through the pandemic from that. We're going to lose anywhere from 800,000 to 2 million nurses in the next couple of years as well. They're just not going to enter the workforce, or they're leaving. from that. We're making the provider now accountable, right, for quality-based care, right, from that. So what makes them stick around? Or maybe they're not, maybe that's why we're losing so many. What makes them stick around? Because it seems like they're working their butts off from that, and they don't seem like they're being able to make an impact or decision on care.
Well, there was a recent number that came out that says that the percentage of physicians that they recommend to their own children to go to healthcare has dropped dramatically. It used to be in the 80s, 20 years ago, 80% of physicians, they wanted the offspring to, they encouraged actually, but they vied for it, but now it is down to 20%. It has become a lot less glamorous. It's a lot more difficult to run a practice. But a lot of physicians got into this thing because of the calling, basically, the nature of their self, try to be the healer and try to make a better impact on people's lives. And frankly speaking, most physicians don't know anything else beside healthcare. So if I quit today, then what next? I can't just pick up and become a financial advisor all of a sudden going forward. So you just basically, after years of 8 years of college and medical school, 3 to 5 years of residency, and it takes you 10 years to get a control of your business, understand the industry or the specialty that you're in. After 20 years, it makes it very difficult to switch. But what is going forward, the physicians right now, I think still you need a physician's signature or provider's signature. The pen is more mighty than a sword. Everybody knows. You need a licensed individual to provide that care that you need. So the system, you can replace like a shell game. Physicians go away and nurse practitioners and physician assistant and other mid-levels come and to take their place. But at the end of the day, you still need the system to function with individuals. But what was mentioned that physicians give the key to the kingdom, they didn't put a fight when managed care took over in the early 90s. And what happened is that the managed care industry owns the individual. You know, at the end of the day, if we want to go somewhere, I'm talking to my client in Southern California. What do you do for your RCM? And he says, we have to go with what the health plan approved vendor is. And if you want to go out of that equation, then you pay out of pocket, and that information never gets to the health plan. That information never gets into your electronic health record or anywhere else that the person goes. So it is, we not only we have to define the roles, the authority has eroded, responsibilities have gone up, and there is the pay mechanism has dramatically been has changed and become distorted. Still, physicians make significant more, have much higher income compared to average American, compared to other industrialized nations. Statistic came from 2022 to 23 this year. Signing bonuses have gone up 20%. There are some specialties that actually get a 300,000 signing bonus. I don't know too many industries that offer that kind of a loan deferment or loan payment for loyalty and longevity with the system. So in the short term, it is what you have. You know, if you have got lemon, make lemonade.
Okay. I'm just going to just point out really quickly. It's interesting. When I'm choosing my specialty care, my cardiologist, if they have switched over to be owned by a health system, I do right from that, because the amount of service just goes to nothing. The firewall goes up right from it, and it's hard to get an appointment with them and everything else as well. So that just
let me add just Optum is the largest, Optum Health is the largest employer of physicians in the United States. We have more than 1 million physicians in this country. A third of them are employed by health systems or other entities. So you're talking about 300, let's say 350,000. Optum Health employs 70,000 physicians in this country. One out of five employed physicians. And it's just a matter of time. If somebody told me about 20 years ago, at the end of the day, he said there are going to be 20 insurance companies and just a few handful of health systems. And as you notice it, we have more and more consolidation in the industry. There's a lot more across the cross-state mergers and acquisitions. And we have a lot less integration. We have more consolidation, a lot more integration of the data. So it is a matter of time. A cardiologist friend of mine, and a world-class cardiologist, after 20 years, closed his office, became a locum tenens. This is just 3 months ago. He says, I couldn't maintain my office, could not pay. He said, the best thing I should have done this 10 years ago, because I don't have an overhead anymore. And now I know I'm going to get paid, and I'm going to get paid. I don't have to send a claim to anybody, fight with any insurance company, I get paid, and I'm done. That's a reality of the new reimbursement model for physicians.
I say too many GPs have with the concierge, right? So they're just really a lot of that. And by the way, Michael's in here from White Plains Hospital. My comments about the hospital, please don't take it personally. Our client, right, as well. So I'm gonna wrap up, from this. I'm gonna open up a little bit to the audience too, but I want to ask one last question of you guys. And it's about, what do you like in the market today? What's innovation mean to you? It's not a small question, right, from that, but what are you seeing something that's going to potentially start moving the needle? Because we went from 1.4 trillion to 2.5 trillion, and 4.3 trillion. It doesn't seem like the needle's being moved much, right? So Marc, let's start with you.
So things that I get really excited about when I see innovation happening. I do think that we're on a journey in primary care. I don't think the book's been written yet. We're in a transitional period between going from traditional healthcare, as was described by these gentlemen, to hospital-based ownership of all primary care. We tried that once in the 80s, right? Now we're sort of trying it again. And now you've got large organizations like CVS buying Oak Street. You have ChenMed and GenMed funded by Humana. I don't know that hypothesis is 100% been proven yet. I would say it's still experimental. If you look at the actual earnings revenue and the overhead of something like an Oak Street or a ChenMed, it's a pretty difficult. It's facility-based. You've got to get people in and out of clinic. You've got to keep things staffed 100%. You have huge infrastructure costs. But the lives from a risk perspective from Medicare are worth it, seem worth it. You can make it work in value-based care. You can make it work in an accountable care organization or some kind of bundled payment, which we used to run at Signify through Remedy Partners. You can recoup savings on the back end, but not every primary care that's trying to make this transition is going to recoup a lot of shared savings on the back end. It's not so simple. They're going to invest, try to attribute lives, and may or may not walk out with a giant check at the end. It's really hard. If you look at accountable care organizations in America, the majority of them are not profitable at the end of the day. They cut even with shared savings, get a small check stroke. It's actually not that easy to do. So I get really excited by novel, innovative ways to deliver primary care that's really consumer driven, consumer focused. I'm a good friend with Tom Lee. I think he was One Medical. He's now working on the new one. I forget the name that he's working on here in New York. Two Medical. And he's trying to sort of really understand what's the value chain, what's the consumer value chain for primary care. What does somebody actually need, and when do they need it, and how can you answer that need very quickly? So, and I agree with Dr. H's assessment, right, which is that there are going to be people who don't have a life-threatening condition, who just need service, and they're gonna walk with their thumb from system to system to system. I mean, if I pulled this room, I would not be the only person in the room who's gotten the shots for my kids at the supermarket clinic when it was convenient, tried concierge medicine for a year and then switched back out of it. went to a big health system, thought it'd be better to be inside the walls. And then, and then the insurance coverage changed, so I bailed. Like, I would not be the only person in the room who's probably sampled a half dozen novel approaches to primary care in the last 5 years. And I see people nodding. I think that's probably true, right? So there you go. So I get really excited about that, right? How do you really deliver that in a patient-centered, patient-focused way? How do you build in the clinical intelligence, which, by the way, as I was trying to make a glib statement before, we sort of have it. We know what works. There's incredible technologies that can show you that the decision tree for oncology therapeutic agents for a new diagnosis of cancer, depending on the order that they are given, because for anybody who's dealt with cancer, you know that you often start with one chemo and then you move to a second chemo and a third. That's all been worked out. A lot of that's been worked out very, very well. You understand what the benefits are and what the costs are, and those equations have been done. That math has been done, but nobody uses it inside the system, right? It's a billing system, so nobody uses that. So I get really excited when I see people trying to come up with novel ways to deliver care directly to the consumer, try to figure out this balance between virtual and in person, right? What we learned in the pandemic is that we can go virtual. We learned in the pandemic that older adults can go virtual. That was always in doubt. I'm a geriatrician, I didn't doubt it, but it had to be proven that older adults know how to use technology and welcome it. But we haven't figured out the equation of how many in-person visits versus how many virtual visits is the right mix for you and for your disease state, and how do the practices accommodate that and do that effectively and efficiently using the technology underneath it, undergirded by card. I get really excited by things like that. I think that in the pharmacy space, there's a bunch of small pharmacy interventions that I get really excited about. Because again, or your experience, your expertise than mine, but I've seen how they've used the data to actually really deliver business intelligence about which medicines are useful when, for how long, when to stop them, and when to intervene on medication adherence. When you see that the pharmacists know everything about you, the doctors know nothing about you, comparatively, right? The doctors see you for X many times per year. These pharmacists know everything about it.
But because they're that intersection point of all your physicians.
Completely, and their data systems have been fully entered, and they have NDC codes. They have the interoperability that the medical doctors don't have. So you can track. I mean, I know how many days it was between when you picked up your statin. If you let it go for 5 extra days, we know that information. We know that you're cutting pills in half. You don't need to confess. We can figure that out with the data. So there's a lot of really cool stuff going on around medication adherence, trying to reduce costs. I agree that RX is really just a coupon service, but there are some more sophisticated versions. So I get excited about that stuff. And you really can sort of use all the data that's out there to deliver models that actually answer people's needs. Because if they don't feel that their needs are met, to answer your question from a second ago in one sentence, what is it that the consumer is looking for? They want to be heard. That's what they want. When they want their rash looked at, they don't want to wait 5 weeks for a dermatology appointment. That's what people want. And I think we have the technology to do it. I think we have the data to drive it. I think the consumers are beginning to make their voices heard. So I get excited when those things intersect. I don't know that the big giant organizations are going to be the ones to master it. I think ultimately it's going to be a lot of sort of small scale innovation that they might gobble up, God willing, for folks in the room. But I don't think they're going to be the ones to lead the innovation necessarily.
Yeah. I'm going to hate to make this comment, but I remember when my doctor went little, he made house call. I mean, like what you live on a farm or something. It's out there, but our doctors go back to house call.
I led a house call practice for several years. It can be done, but again, it has to be done with the intelligence system. Yeah. Otherwise, they'll spend an hours on 5 visits a day with 3.5 hours of driving time. It's just not going to work.
Yeah. Ross, your thoughts on what's exciting you, innovation from that?
Sure. So I'd say a combination of technology and delivery models. So starting kind of with the problem solution mindset. So take some of the emerging drugs that are coming out into the marketplace. monoclonal antibodies for Alzheimer's disease, an example. So we don't actually have the infrastructure in the country to actually administer those drugs. And the drug companies aren't gonna solve that. And I know the folks at Biogen and Lilly well. And there's now an increased acknowledgement by those folks that the drugs are going to be in the market and being underutilized as is happening with lecanemab, because the infrastructure is not able to keep up with the innovation. In this case, the innovation is the drug. And so there's some really interesting models emerging that I think will do a couple of things. One is they'll create greater access points for members. So the innovation is going to force certain things to happen. So and this happens when you have a solution that you didn't have before. So it's sort of, and you see this repeatedly in medicine. There's sort of the days before and the days after. And the days after, we go through this really awkward time frame where the system can't accommodate it, and then in good outcomes, you actually end up with a better system. So what do I mean by that? In this instance, it is in the interests of neurologists to be integrated with family doctors and internists, to be integrated with infusion centers, to be integrated with the rest of the health system that actually understands how to do the safety monitoring required for the delivery of that drug. There are a lot of moving parts and pieces. So I'm familiar with at least a couple of companies that are using a virtual chassis to do early stage and sort of at risk Alzheimer's care. So it's memory care, in an app, not entirely, with real board certified physicians and layers of case managers providing support to help enable a few things. One is the pharma companies need to find these patients early enough in the stage of their disease life cycle, otherwise the drug doesn't work. Those people are not seeing neurologists, they're seeing primary care doctors. And maybe they're just having some minor memory lapses and not real sure, and the spouse is concerned or whatever. But all the docs are too busy to take care of that. If there's an easy button where you can say, well, we have memory care in a box, because there's only 30 or 40 AMCs in the country that actually have real memory centers. And so that misalignment does actually create, and the interest of a drug company that wants to see their innovation diffuse, creates the impetus to do things differently than you've ever done them before. And the ability of technology through through video visits, use any kind of technology tool that gets you more engaged. And when you live in the majority of towns where you can't see a neurologist and you can have that visit from a video format, if your initial doctor has said, I'd like you to do this, and we've talked about that when it's recommended by the doctor, whether it's Life365 or some other alternative approach to helping with diagnosis or monitoring, people are definitely more comfortable with that. So we'll see that emerge, and we'll be able to create greater access to the innovations, which will also be from the business modeling point of view, will incent the lowest possible cost sites of care than the current system generally is equated with. So I think that's something I'm seeing those models emerge in dermatology. So these are all, what they have in common is we have an abundance of high cost drugs, and so disease states that weren't that costly now are. And now you have a mismatch in access to expertise. So you need decision supports or pathways delivered in a way that is seamless for physicians, so they actually maybe don't need to go through the awful prior authorization, mother may I world of having access to a drug, rather than utilizing a decision support platform that's built into their system, which fully demonstrates that they are following the auditable appropriate use criteria, which are peer reviewed and are now embedded in their systems. this isn't all completely assembled, but it's being assembled. The emerging work that companies like Epic are doing with Microsoft, as an example, I think is just going to accelerate that in a big way. And you'll be able to sort of query the system for these sorts of verticals. If somebody has a business imperative where they want to look at autoimmune disease, or they want to look at MSK or any one of these things, and you would say, well, who are the folks that are headed for trouble where, gosh, we should be advancing their physical therapy sooner, so they're not advancing into higher costs and declining health. We don't do any of that sort of radio signaling as often as we ought to, and Marc mentioned it in several different instances. So that's an example of the use of technology and sort of system innovation and that I'm very excited about. And I'll mention one other, and the theme here is sort of community-based organizations, I'll call it non-traditional teams. So we don't have enough docs, we don't have enough nurses, we don't have enough sites of care, and you have people who want to help. And there's some really interesting work through Dr. Ken Govey at Penn and some other places using community health workers. And I mean, this is old stuff. When teams went to Haiti and Africa to work on the first HIV clinics, that was all performed with community health workers. They had a protocol, they had a couple of docs, maybe a couple of nurses, and just an army of community health workers. And they created protocols, and they were actually able to do great things with the lowest common denominator that would get the job done. And I sort of, and you're starting to see models, Main Street Health as a rural care, primary care, Medicare Advantage, at-risk, full cap model embeds community health workers. We will show you practices how to use community health workers. You can do that. And it's these spaces in between that remote monitoring helps with, but it would even stronger if you have a human in there saying, hey, your doctor wanted you to use that device, make sure you're using it. And so we're seeing more the emergence, both in sort of from the medical issues, community health workers, maybe for chronic diseases. You're seeing more, and this is actually changing on the regulatory front, the ability for licensed social workers or behavioral coaches actually to be skilled in a certain way where folks will have greater access to behavioral health support. So you'll see fewer escalations. I think that's pretty exciting to see, provided that we integrate it in the rest of the system appropriately. And I think there are folks, we'll have some misses, but I think there are folks doing that well. And then finally, I'll talk about sort of the space outside of healthcare. So when you look at important issues around food, transportation, shelter, all of that, there's a large portion of the population that are stressed somewhere in there that leads to exacerbation of bad things happening. They get worse prenatal care, and they have unhealthy diets, or they're living in food deserts or whatnot. Much of that is sort of superimposed on the chronic behavioral health population, and that leads to spiraling medical costs because they get no attention, because in their hierarchy, medicine is just not their concern. There are some really interesting models, and I had dinner with one company from Nevada last night, and I'll name drop them in case anyone's interested. That's Novum, N-O-V-U-M, and they're doing some really authentic work, and they decided that we're going to go at this behavioral health model going full cap from the beginning. They found an innovative payer that would help them get started by actually fronting them some dollars and saying, all right, we believe in you, because the entrepreneur had a track record, and they said, we'll give it a roll. And what they have done is they've created a community. And what's really, really interesting about their model is that when they move into a new community to take care of these folks with severe or moderate mental illness, and create a site of care, which actually provides food access, which has pharmacy on site, And, and CHW's community health workers to sort of help them if they're having issues at their homes and so on. So they'll take that risk, but in addition, and this was, I've seen versions of this, but this was really pretty elegant. They'll support the Salvation Army, they support the food kitchens in the communities. They actually go out into the communities, not to just capture patients and bring them in, but to actually support the infrastructure that already exists in the community, so that those people who are living parts of whatever the community is, they become the alert system that informs the care deliverers that we have somebody who I think's fallen off the rails. Somebody came into the Salvation Army and we know you at this behavioral health center because you came in here and made some donations and you actually help us. And so they're creating, authentic relationships, human to human, that are creating a wraparound which accommodates the social needs of the population in an authentic and integrated manner into the medical care that they're receiving. And that's a business model that I think you could actually apply to some other areas as well. So stop there.
Awesome. You can actually pay for that kind of expertise for you guys, right? It's great. I guess you could pay for it, right? But it's invaluable. Mehrdad, I'm going to give you the last time to wrap up. We give you a choice of 3 questions, right? Either you can do the innovation question right from it, or you can talk about value-based care, community-based care, and hospital at home, right? Or pros and cons between Kravitz, Kelsey, and Taylor Swift, right? So two. Okay.
Number 2.
Yeah.
Well, going back to value, let's start from fundamentals. Finance 101, value is cost over quality. Now, whenever you see it in healthcare, basically buyer beware, because value-based care in healthcare, my opinion, I'm transferring my risk to you. The payer is transferring the risk to the provider. And I have given value-based care contracts to so many providers that basically there's a watermark in that paper. And the watermark is, what I want you to do is my high cost items, which is inpatient care and emergency department. I want you to reduce that and add more tomorrow. My outpatient care and pharmacy. If you do this for me, there's going to be some savings and I'm going to share half of it with you or a third of it with you whatsoever. So basically, that is the watermark behind all the contracts. I want cost of category of expense from this bucket come to this bucket. That is the nature of it. However, there is significant opportunity here is you can at the same time simultaneously improve care. That would be the true value of a value-based contract. It should not be only cost saving, because vast majority of cost savings are a one-time deal. You make it now, but it is not a repeatable occurrence for you next year. So you have to have this sustainable model that allows you to have increased revenue, decreased cost, better care outcomes. That would be the true example of a value-based care. How many of them do you really see? Very, very few. More than 90% of it that I see right now are purely financial. It's cost reduction without, and again, a lot of ACOs, as was mentioned, jumped on the bandwagon and they just improved their HEDA scores. And after they did that, or they just come up with some cost cutting, there is nothing there. We know ACOs that have 280 physician members that have dwindled to 20 because everybody else said there's no money here and I'm walking out of this. And they are, at the same time, I have had the pleasure of working with a client that has had phenomenal growth, has had significant member retention, significant cost reduction, and at the same time, increased revenue for the health plan and improve the quality metrics. All 5 elements of this thing came together. That, and then they were able to have so much excess money to do a lot of things that they could never imagine, expand to different counties, compete with giants of the world like United Health going forward. But going back, it starts with engaging the member. If a physician sees a patient for half an hour, for the sake of conversation, half an hour, let's say once a month, that is almost 1,000% of a patient's time out of doctor's office. We have no information outside. After that, when the patient leaves, there is very little information or feedback or follow-up with that provider. So what is really exciting to me, and I'm combining the two things together, it is now attention to social determinants of health, that we know the major, we did an incredible analysis and we found out preventable readmissions have at least 2 social determinants of health. 2 out of 6 that we can accurately and consistently measure: transportation, housing, social support, finances, health literacy. These are the social determinants. Now there is the impetus to start managing those, addressing those at the community level. The second thing is now you are interested in providing continuous care and use of technology. Again, this is a tornado that is getting together, that you have aging populations, you have increased demand for technology, and now you have need for decision support to get all these noise that is coming, separating and converting to signal, convert signal to information, information to knowledge. That is where this is going. For me, it's a very exciting, because there was no model for this thing 20 years ago. When I was young and I wanted to improve care, I just developed this program and I went to my chief medical officer and I said, we need to implement this thing to improve asthma. And he told me, you're putting super unleaded gas in a rental car. That was the response. We're not going to do that. And when I left and I implemented that program, I won a national award for improving asthma care. We decreased ER visits, inpatients admissions. We improved all kinds of metrics that it was there. But now there is a model, that is a financial model that's coming into play, that is going to reward that you actually can bill for remote monitoring. You can bill for remote case management, consultation with other physicians, other providers. Kent has 20 of these CPTs on the website available, that providers who provide this service to their members can actually get reimbursed for it. There is a model for it. So you're getting out of the hospital, you're getting hospital at home, right? And for hospital at home, you only need one thing: remote access monitoring. That's all it's based on. You have to be able to monitor people where they are and deliver care that it is. McKinsey did a study last year. They published what the 10 things is healthcare is going to look like. It's going to be more transparent. It's going to be more value-based. It's going to be more ambulatory. It's going to be more investor supported, and a lot of other virtues. So I'm excited that this is the perfect storm for technology to improve care outcomes that reduce cost at the same time.
Thanks, Mehrdad. I really appreciate it. I really appreciate Dr. Hoffman and Dr. Rothman for being here with us tonight. Great insights from that. They're going to be available afterwards to have a cocktail with, right, from this. And I just want to have you give a round of applause.
Can I ask a question?
Yeah, absolutely.
I'd like to ask a question back to, if you see large scale use of the technology, aka Life365, for deployment, operationalizing, and hardening on a broader scale, what is your opinion about who best, I use the word loosely, owner or purchaser, and who should be the recipient of the technology? And then secondarily, how do you impact the consumer with that answer? If that makes sense. And I'm talking about pharma companies, the payers, providers, retailers on that question? If we're looking at larger scale use, what do you have an opinion about how to best deploy it?
Well, again, at the end, I've worked a lot on the payer side. Payer is the one who owns the member.
Yeah.
Payer is the one that controls who this member is. We call it member, who patient sees, where they get their drugs from, which DME manufacturer they get their devices from, etc. So it must be a partnership with a health plan that actually has the maturity understanding of their population and looking at who is the population that they need to impact most. If you go in a health plan right now, the traditional view has been, who is the top 5% of people who are the costliest in your network, and start managing those people. If you look back at this 5% membership, quarter after quarter, they're not the same people. 50% of them change. Either they leave your plan, either they get celestial admissions, or they go somewhere else. They're not there anymore. But coming back, you have to have a targeted audience, and you have to have an understanding of population health. You have to have significant tools for engaging your membership. The membership element of trust is fundamental to having any patient engagement, and having those dedicated people that support the individual. You have partnership between physicians and the health plan, the payer, that they do not get penalized for taking care of their costliest members, and going from there. It can be done. It has been done in self-funded models, in closed models. I used to work at Henry Ford Health System in Michigan. We were a totally closed model, and we managed our membership incredibly well before other things that happened. Yes, it was that patient had one single electronic health record.
Yeah.
One single electronic health record, one pharmacy. It included every single thing of what this person was known to the entire medical group, and we were able to manage it successfully. And then there was the element of trust between physician and patient, that they knew that this person is proposing this kind of a treatment because it's beneficial to the individual. And then having some business savvy. That's another, the innovation must be ingrained in a company's DNA before you can import it from outside.
We're gonna wrap up really quick.
Sorry, thank you.
For that, so, because I don't want to keep you guys here all night, but this is a great panel, and I encourage you to, talk with Mehrdad and Ross and Marc, during our cocktail after this, right, as well. So thank you again, everybody.